topic is colorectal and beyond that. So anorectal diseases of rectum and anal canal. What about hemorrhoids? Hemorrhoids, the position 7, 11 and 3 o'clock. You see this in lithotomy position. The position has to be lithotomy. You are seeing from down. So this is 3 o'clock, this is 7 o'clock, and this is 11 o'clock. So this is the anal canal. This is 11, 7, 3. You are looking it from downward, from front. Patient in lithotomy position. So these are the 3 prolapses is like this. That's why 7, 3, 11. What is the clinical picture is bright red rectal bleeding on toilet paper. This is bright red. Question is like this: toilet paper, bright red. There is no pain generally, painless. Sometimes, unless that is get thrombus and all that. Swelling from external hemorrhoid and internal one is not palpable. If it is outside, you can see this is external. If there is internal, you will not palpate anything. Even if you do rectal examination, it will be soft, so you will not feel anything. What is the treatment? First line of treatment, it depends upon the grade 1, 2, 3. So 1 is grade, it is just inside, there is no prolapse. 2 is little bit coming down, hanging down. 3 is still, it is not coming out of the anal opening. Here you can see 4, it has come out. So this is grade 1, this is grade 2, this is grade 3, grade 4. Grade conservative or rubber band ligation. In this 1, 2, 3, you can ligate this. This is ligate or clipping with the rubber bands. If it failed, then you have to go for, this is prolapsed. Grade 4 is prolapse. It has come out of the anal canal. Hemorrhoidectomy is the treatment of choice. Posterior 90% at, now what is that? This is the anal fissure. Here hemorrhoids is over here. Coming to anal fissure, 90% is midline at the 6 o'clock position. So this is 6 o'clock, midline. This is the question. 90% is midline posteriorly and only 10% is anteriorly at 12 o'clock. Anterior fissure most likely to be due to ischemic bowel in women. Posterior and below the dentate line, bright red, constipation. This has to be, this is dentate line. This is dentate line. It is to be below dentate line. Examination in case of acute fissure, mucoepithelial defect, usually in midline posteriorly. In chronic cases, ulcer or sentinel pile is enlarged anal papillae. Laxative, first line of treatment is laxative pain, topical glyceryl trinitrate, GTN, diltiazem, glyceryl trinitrate. Then botulinum toxin can be injected, or if this is not relieved, that is lateral sphincterotomy. This sphincters, it has to be broken down, that is by anal dilatation. It is called as by anal dilatation or by cutting, so that the spasm is relieved, and this pain is because of spasm in the sphincter. So anorectal abscess, it's common question. Location perineal, most common. Perineal, this is called as perineum. This is all perineum. Ischiorectal, in between the, this is the ischiorectal space. This is levator ani muscle, external sphincter. This is the inside. So these are the 3 muscles: levator ani, external, this external sphincter muscles. This is the internal. In between the, and here is the pudendal canal. So question is, it is medial to pudendal canal, lateral to anal sphincter. This perineal most common, perineal. So this is perianal. Perianal, it is so much superficial. Most common is perianal. Then this is ischiorectal. Then this is intersphincteric. This is internal sphincter, this is external sphincter, in between the sphincters. Intersphincteric, it is pelvirectal. It is, and this is supralevator, means this is the levator ani. It is above that. So most common is perianal. This is the anal canal. This is perianal dental line. E. coli and Staph aureus. Severe pain, fever, swelling, surrounding erythema, cannot tolerate digital rectal examination. So pain is so severe that this is swelling. So cause is E. coli. Now intersphincteric. Most common is this. Now this is anal fistula. This is abscess. Most common abscess is perianal according to this, and this is intersphincteric. Now when you go for anal fistula, there is an external opening and there is internal opening. Among this intersphincteric, in between the sphincters, it is like going like this, external, internal. That is most common. Transsphincteric, suprasphincteric and extrasphincteric. So it has to through and through. Intersphincteric is like this, through and through transsphincteric, suprasphincteric very high, and extrasphincteric. So what is this Gutsal rule? You are seeing in the lithotomy position, this is posterior side, this is anterior side. If fistula is located anteriorly, most of the time it is straight path, internal opening is straight. If it is situated posteriorly, it has curved path and internal opening is midline. Okay, it has to be less than 3 cm or something like this, the anal opening. Because just keep in mind the anterior opening straight path, posterior opening curved path, internal is in the midline. May initially present with abscess. So what is there? Fistula, how it is happened? Initially there is abscess, any of the abscess. This burst, internal opening burst inside, and then persistent discharge in perineal region. Fistulogram is the best choice of investigation. MRI is investigation for recurrent fistula. No sphincter involvement, no IBD, low fistula, just lay open. If complex high fistula, insert seton. IBD, ischemic bowel disease, Crohn's disease or something is there. Seton is the mostly loose seton to encourage both drainage and fibrosis. Don't probe, it may lead to acute sepsis. Coming to rectal prolapse, risk of multiparous women or children with rectal interception, lifting heavy objects, constipation may be internal, external. External prolapse is evident, but internal may need colonoscopy, defecation, proctogram, manometry, and all this. Treatment in acute setting, reduction of the prolapse has to be done. You have to push it. Then what is a definitive treatment? Rectopexy. Fixing of the abdominal posterior rectum is elevated and supported at the level of sacral promontory. Another is dilorum, that is excision of the mucosa. Ultimers, where the colon is resected. So rectopexy is fixation, dilorum is mucosa is excised, and ultimers is the resection of the colon. Pilonatal sinus. What is the cause? Natal cleft, male patients, because excessive hair debris create sinus in the skin. Bascom's theory. This is theory of Bascom's. Male, debris hair, and lodging of this. Clinical picture describes the cycles of asymptomatic, then periods of pain and discharge from the sinus, acute and complicated with abscess formation. No treatment in cases when acute infection or abscess. Definitive treatment is required is the Bascom's procedure, excision of the sinus and obliteration of the underlying cavity. Angiodysplasia. Atogenous malformation, common cause, significant lower GI bleeding is there. Angioembolization, continued bleeding with negative intervention, total colectomy is a life-saving. Anal cancer. Coming to this, strongly linked with the human papilloma virus 16, anal intercourse, smoking, and other anal immunosuppressions. Cell of origin is squamous cell epithelium, so it is anal canal. Site is arise inferior to the dentate line. Anal clinical picture is discomfort in the anal canal, pruritus present with aggressive fresh rectal bleeding. Investigation, diagnosis is made by examination under anesthesia and biopsies has to be done. First line of treatment is chemotherapy for anal malignancy. Squamous cell carcinoma is better treated with the chemotherapy. Second line of treatment for metastasis disease is radical abdominal, non-metastasis. If patient is not having metastasis, radical abdominal perineal resection if it is low. Inflammatory bowel diseases. This is very commonly asked question between ulcerative colitis and Crohn's disease. What are the main differences? Definition of ulcerative colitis is ulceration of the colon. Chronic transluminal. This is mucosal. This is granulomous inflammation. Extent is all colon to dentate line may affect rectum only. Sometimes it is only rectum or proctitis, but it may affect colon up to dentate line. Anal canal may be from, but this is Crohn's is mouth to anus. Most common terminal ileum. Terminal ileum is common. It can happen anywhere from mouth to anus. So macroscopic extensive ulceration is there in ulcerative colitis, while here granulomas are there. There is no skip lesion. It is continuous. Here you can get skip lesions. This is the common microscopic finding. Crypts, abscesses are seen. Pseudopolyps are seen in ulcerative colitis. There is transluminal affection. Transluminal, through and through. Clinical picture is bloody diarrhea and mucus. Alternating in both the thing, bloody diarrhea, mucus is there. Heat can cause to toxic megacolon, precancerous, massive hemorrhage. This leads to fistula, fissures, perianal fistula, malabsorption, bile salts, secondary terminal limb disease, short bowel limb syndrome, recurrent. Intestine complications, ulceration, suppuration, perforation can occur. Fibrosis lead to strictures formation. What are the extraintestinal manifestations? Ulcerative colitis, there is erythema nodosum in both pyoderma gangrenosum, erythema nodosa, pyoderma gangrenosum, arthritis, ankylosing spondylosis, renal stones, arthritis, eyes, joints, spine, skin, pyoderma gangrenosum. So uveitis, uveitis, closing cholangitis, PSC, primary screening cholangitis. So there is no polyarthritis in IBD. Arthritis is this, polyarteritis is not there. Episcleritis, gallstones can be seen in Crohn's disease. Investigation pipe stem, and here there is cobblestone, string sign of contour, CK, Crohn's contour, and here is loss of ostrations, pseudopolyps, pipe, drain pipe, and here is cobblestone. Corticosteroids, salicylic acids, diet. Surgical treatment is elective. Long use of steroids, ulcerative colitis with risk of malignant transformation. Proctocolectomy, complete with ileoanal pouch. Acute external colitis, emergency operation, subprotocolectomy with ileostomy. Surgical emergency only. Indications, common complication, interstitial fistula and all. Resection terminal Crohn's with limited ileosection, strictures, stricturoplasty. Crohn's disease is a contradiction to having a ileoanal pouch is not done because it can lead to pouchitis. Development of colorectal cancer in patient with ulcerative colitis associated with less than 15 years old, disease confined to rectum, poor compliant with treatment, unremitting disease. So coming to intestinal fistulas, abnormal connection between the two hollow organs, classification according to outputs, high output, low output, cutaneous from skin to the intestine, duodenal, jejunal will have high output fistula, lead to severe excoriation of the skins. So a higher level fistula will lead to alkalosis, loss of acids, lower loss of bases. Enteroenteric fistula, malabsorption syndromes, enterovaginal fistula, stool from the vagina, enterovesical, there is nematuria, urinary tract infection, passage of gas, that is nematuria. Conservative treatment is SNAP. Sepsis may be best option. Sepsis is there, skin involvement is there, nutritional support has to begin, anatomical localization. Then no surgical intervention if no distal obstruction. If there is no obstruction, don't go for surgery. Anastomosis are higher risk for developing lichen fistula. Coming to intestinal obstruction is blockage of prevent of food or liquid from passing. Different types, paralytic ileus is for it because of hypokalemia, electric imbalance, and this is functional. And mechanical is because of extrinsic lesions, adhesions, hernia, volvulus, intra-abdominal abscess. In intrinsic, it is the origin in the wall, maybe malformation like atresia, duplication, large bowel neoplasms, small bowel neoplasms, strictures, ischemic, diaphragmatic abscess. It is condition characterized by division of bowel lumen into series of short compartment of circular membranes. These are diaphragm. Diaphragm means this is a partition in the lumen that may cause to obstructions. attributed to non-steroidal anti-inflammatory drugs. Intraluminal obstruction, normal intersusception, gallstones, webs, fecal and meconium, interhematoma, foreign body parasites. Clinical picture: persistent vomitings and absolute constipation. Now it is abdominis, tympanic, peritonitis, perfusion. X-ray abdomen, the first line of investigation will show air fluid levels, while CT scan is with contrast is the investigation of or the cause. Treatment of the cause depends upon if it is volvulus. Twisting the volvulus around the sigmoid colon volvulus is very common. Patients usually present with bloating, and examination shows a massive sigmoid colon that is called as omega sign. This is omega sign. This is omega sign. Treatment is you have to retwist sigmoidoscopy and ischemic colon is there, then you have to go for a resection of that. This is Ogilvie syndrome. What is this? Is pseudo obstruction. Symptoms, signs of large bowel obstruction, but not. It is associated with electrolyte imbalance. This is because of electrolyte. It's not any mechanical obstruction. Abdomen is tense. It is not painful but full. You have to correct the metabolite neostigmine for motility and colonoscopic decompression. What is diverticular disease? Presents pouches in the wall of large bowel. It can occur anywhere from in the large bowel, but most of the time common on the sigmoid colon. The left-sided reactfossa pain most commonly in the left. Altered bowel habit, constipation, diarrhea is there. Diverticular most common cause of GI bleeding. Lower GI bleeding common is diverticuli. Because of increased pressure, there is formation of diverticuli. Inflammation, diverticulitis, perforation. What will happen? Diverticulitis, perforation, bleeding, stricture formation, fistula developing, divertic phlegmon. Acute attack, if suppose it perforates, there can be peritonitis and fistula formation. So CT angiography has to be done. There is Hench's classification 1, 2, 3, 4. One is paracolic, surrounding colic, there is abscess. If it goes into the pelvis and abscess is there, that is second. Purulent peritonitis, generalized peritonitis, but it is pus. And fourth is fecal peritonitis. Para, pelvis, peritonitis, purulent, and fecal. So these are the different classification of Hench's classification. Diverticular diseases, increased dietary fiber, because increased dietary fiber intake, mild attack of diverticulitis managed conservatively with antibiotics. Recurrent episodes of acute diverticulitis require hospitalization are recurrent episodes of diverticulitis requiring hospitalization are relative indication for resection. Paracolic abscess drained either surgically or radiologically. So what is there? Diverticular disease is increased dietary fiber intake, mild attack of diverticulitis. It has to be managed by antibiotics. Recurrent episodes of acute diverticulitis require hospitalization. Paracolic abscess, just an abscess, it can be drained, but Henchi 4 and 3rd, generalized and fecal peritonitis needs laparotomy. Diverticular bleeding, you have to go for conservative. These are the abdominal stomas, different type of stomas. Stoma is bypass, it is just whatever contents we are letting it out. So this is called as loop, you have brought the loop out. This is double barrel, this is one barrel, this is another barrel. From here it is all out. This is the mucous fistula, this is the terminal stoma. Diversion of the intra-abdominal luminal contents, types of temporary colostomy, it can done to decompress. Diversion is equally facilitate the distally. Permanent colostomy, in which you do resection of the further part and in the left iliac, 6 cm above the and medial to anterior superior spine. From anterior superior spine and medial to loop and a double barrel. Complications. What are the complications that may occur? Prolapse is most common. Dermatitis, because this is prolapse, it's coming out. And dermatitis, common complication. Necrosis, earliest complication is necrosis. Whenever you try to bring it out and you suture it to the skin, this may get necrose and it may get retract after necrosis. So necrosis, it happens within hours or within a day. Then retraction, it may go into retraction. Then herniation is the late. All other things, peridermal skin excoriation. Coming to colonic cancers. What are the genes responsible and genetic relation with this? Familial adenopolyposis, adenotic FAP, APC gene, FAP. So more than 100 polyps, 100% precancerous. Multiple polyps, duodenal cancer, associated colonic, gastric and desmoid tumors. MYH, the gene is responsible, right colon. Lynch syndrome, DNA repair gene fault, right colon mucus. Peutz-Jeghers, hamartomas are there, pigmentation is there, STKNB. Coden, P10, DEN 10, Jogar, LKP, STK, hamartoma. Lynch, you are lynching, right mucus, mucinous. Coden, breast, thyroid, uterine. So, familial adenosis polyposis, what is there? Autonomic dominant, this is dominant condition. All these syndromes are autosomal. Autosomal dominant, except MYH syndrome, MYH, which is recessive, MYH, recessive. Lifetime incidence of colorectal cancer is untreated FAP is 100%. So, familial adenosis polyposis is there, this malignancy chances is 100%. Gardner syndrome is equal to Fadden polyposis plus desmoid tumors. Gardner, D is there, desmoid, Trucut, CNS. Jigger, pigmentation, Corden, P10 gene. The likely diagnosis is one of the familial cancer syndrome and now has developed colonic cancers. HNPC is the Lynch syndrome. We are seeing here Lynch, DNA repair gene, right colonic mucosa. Lynch syndrome, hereditary non-polyposis colonic cancer. Colonic cancer without extensive polyposis, few or no polyps. Extracolonic malignancy, endometrial, ovarian, gastric, these are the extracolonic. Management is surveillance colonoscopy, prophylactic hysterectomy. So family patients, relatives has got malignancy, bilateral oophorectomy and can be after childbearing. Colectomy before development of cancer. Aspirin therapy is decrease the risk of cancer. So colorectal cancer, 90% is adenocarcinoma, glandular epithelium, mucinous is 5%. Signet ring, small cell carcinoma, oat cell carcinoma can also end. Rectum is again more common, sigmoid colon is the next, and cecum is then. So if it is annular, it is stenosing, this is tubular, long part, this is ulcerative, and this is cauliflower. So if you go for this TNM staging and Duke staging, first let's see for the Duke staging A, B, C, D. What is there? D? D is distance metastasis, and C is for the involvement of the lymph nodes, and B is tumor invading the bowel wall through and through. This is limited to bowel wall. It has not invaded the serosa. So 5-year survival is very high. No lymph node involvement, no invasion. Here there is no lymph node, but it has invaded the bowel, so 75%. Lymph nodes is there, one level lymph node metastasis is there, 50%. So if you see at T, 1, 2, 3, 4, N0 is no lymph node, N1 is 4 less than 4 lymph nodes, N2 is more than 4 lymph nodes, M1 no metastasis. And now seeing for the T, 1, 2, 3, 4, this is mucosa and submucosa. This is up to muscles. This has invaded the perirectal. This is adjacent structures, bladder and surrounding structure. So how patient presents with this? The clinical pictures are, these are the lymph nodes. Here is a tumor. Patient has got, because of tumor, anemia, mass, like appendicitis, interception, pericolic, all this. If the tumor is situated here, there can be urinary symptoms, fistula, hydronephrosis, lumbar shelf, rectovesical. If the tumor is situated somewhere here, tumor left side is obstructive, paracolic tenesmus, mucus, mass here, and there is fluid ascites, enlarged lymph nodes, pleural effusion, secondary loss of appetite, decreased weight, supraclavicular lymph node can be there. Investigation is, there are two types. One is for screening, another is diagnosis. So screening has to be done in the patients which have got family history or something like that. NHS have national screening program for screening every 2 years to men and women 60 to 69. They need screening. Eligible patients are sent for fecal occult blood, FOB. There is blood or in the fecus or not. Patient with abnormal results. Out of this, those who are abnormal, when to suspect cancer colon? Essentially, following patient need referral, altered bowel habit more than 6 weeks, onset of rectal bleeding, tenesmus. These are the suspect. Best investigation is colonoscopy is the investigation and gold standard. If not available to use, then contrast colonography. Once malignancy diagnosis is done with colonic cancer will be staged using CT chest. Patient with rectal cancer proceed to MRI scanning. What are the tumor markers? Carcinoembryonic antigen, CEA. This is the tumor marker. Not all tumors are secret, it may resist the condition. You may ask yourself two questions. Where is the site and what is the whether medical emergency is there or not. Right side, whether it is obstructed means emergency, non-obstructed means elective. You have to go for colectomy. Whether it is emergency, non-obstructed, right side you have to go for colectomy. Left side, if it is obstructed, very obstruction without perforation, you can put the stent, relieve. If sepsis is unstable, not qualified surgeon, then in stoma with resection, just stoma. Resection and stoma. Left side you have to bring resection and stoma. Non-obstructed means patient is planned. Resection according to site, chemotherapy has to be given. Now this is sigmoid colon. There is the head part. So elective sigmoidectomy and colorectal anastomosis, obstructing sigmoid colostomy and Hartmann procedure. So this is an emergency. Don't do go for elective. Then CA rectum. Now this is the lower level. Still obstructed, you have to go for loop colostomy or you have to go staging radiochemotherapy. Non-obstructed, even limited, no lymph node involvement, surgery has to be done. Involvement of the anal sphincter or low, very low, lower third, then abdominal perial resection, permanent colostomy. If rest of the anterior resection and covering ileostomy and anastomosis has to be done. If it is T4, T4 radiotherapy alone, therapy long course. Treatment of liver mets, first side from the liver mets from the contact liver is still potentially curable. Without resection, 5 years survival for the best outcome is seen with the chemotherapy. So interior resection, inferior resection, high anterior resection. This is anterior resection, high anterior resection, sigmoid colectomy, left hemicolon on the left side of per colon, right hemicolectomy, perineal resection, total proctectolectomy. These are the different procedures. So carcinoid tumor, Kurchatki cells, vasoactive amines, chromogranin, histamine, 5-hydroxyindoleamine, serotonin, all these are the secreting. 45% is in appendix, ileum. Then many flushing of the face, these are the symptoms. Then 5-hydroxyindoleamine 25, urine is there, serum chromogranin is there. Medical treatment is octatride is the treatment of choice, surgical removal is there. If it is deep and more than 2 cm appendectomy, less than 2 cm, more than 2 hemicolectomy has to be done. Mesenteric vessel diseases, mesenteric ischemia accounts for 1 in 1000. This can be acute mesenteric embolus, superior mesenteric is the commonest. It is occurs in splenic flexure. So acute mesenteric embolus, sudden onset abdominal pain, profuse diarrhea, vomiting, rapid deterioration, WC count is raised. Mesenteric vein thrombosis is usually slow, abdominal aneurysm has reached a stage to compromise arterial flow. Thrombophilia accounts for 60% of the cases. Acute and chronic mesenteric ischemia, usually longer prodromal history of abdominal discomfort. Patient will usually present with acute and chronic event, but otherwise will tend not to present until mesenteric flow is reduced less than 80%. Low flow mesenteric ischemia occurs in the patient. Multiple comorbidities are there. Diagnosis. CT angiography is cornerstone of the diagnosis. You have to go for CT angiography. Which vessel is impaired? Superior mesenteric artery duplex ultrasound is useful in evaluating proximal superior mesenteric artery disease. Serological tail WBC count has to be done. Management is laparotomy if peritoneum is sane. If mesenteric vein thrombosis is there, no peritonism. Medical with IV heparin has to be started. Operative limited resection, frankly including relook laparotomy. So what are the miscellaneous? Chronic use of laxatives may cause melanosis coli, Meniere's disease, protein losing enteropathy associated with hypoalbuminemia. Whenever there is loss of albumin, that leads to protein. Celiac disease, gluten sensitivity, T cell lymphoma. So this was about lower GIT.